Okay, I've been asked to talk about when to stop resuscitation, and I'm going to start with a story. A 57-year-old man had heart disease, and he had a narrow escape, so he decided to retire. He sold his business, moved to the coast, and was going to unpack, but decided to go to bed, do it in the morning. His wife was woken up early the following morning by some abnormal breathing sounds. She looked at him, couldn't rouse him, saw that he stopped breathing, called an ambulance, did CPR. The paramedics came, did a fantastic job, intubated him, CPR, saw he had VF, gave him several shocks, gave him adrenaline, couldn't get an output back, and he died. They got to the end of their algorithm, the algorithm got to its end, and so did that patient. And I think everything was done, and that case is kind of clear-cut. And there are other cases when deciding about resuscitation that are clear-cut. There are some cases where it's clear it's inappropriate to even start resuscitating. And then there might be external factors. So in pre-hospital care, there might be a situation where the rescuers are becoming in so much danger, they have to stop resuscitating to save themselves. But what about most of the resuscitations that we do? Is it straightforward or isn't it? On the face of it, I think it is straightforward. I think there are three situations you can apply to decide when to stop resuscitating. One is the patient doesn't want it. Number two, there is no chance of a meaningful recovery. Number three, there is nothing else you can do. So let's take these in sequence. The patient doesn't want it. If you've got an advanced care directive, you know the patient doesn't want it. That's easy. But that isn't always the case. And the majority of the time, we do not have this information. And it takes time to get information about patients' wishes from their family. And even though the public may have inappropriate expectations about outcome from cardiac arrest from the media, we really owe it to them to give them the benefit of the doubt if we don't know what their wishes are. Because if we assume they don't want it, we're closing off a lot of options to them. There is no chance of a meaningful recovery. Sometimes we might be overconfident in making this call. When is there no chance of a meaningful recovery? Let's think about the situation of an acute arrest in a patient with no significant major premorbid pathology. How long can they last on CPR before they become unsalvageable? Now, some ambulance services, including the one I work for in New South Wales, have protocols on this. Our one is that if the patient is in asystole after 20 minutes of CPR and they've not found anything that they can immediately reverse, they call it on scene. They do not convey the patient to hospital. One of the reasons for that is health and safety reasons. It's ineffective and potentially hazardous to attempt CPR in the back of an ambulance if you're doing it manually. But with the advent of mechanical CPR devices now, there is no good reason from a health and safety point of view not to be transporting these patients with good, effective mechanical CPR in place. So what else can we use if it's not duration of CPR? What about clinical signs? Maybe there's something about looking at this patient that says, yep, we can call it. Examining the patient, the pupils, is that helpful? It's not helpful, is it? We know even after return of spontaneous circulation, unresponsive pupils, dilated pupils on day one don't necessarily portend a negative outcome. The converse is true. If they've got reactive pupils during an arrest, that's very favorable, but unreactive pupils are not that helpful. And in fact, there is no clinical sign that can predict a bad outcome on day one. What about end-tidal CO2? I love waveform capnography. I talk about it all the time. And it is helpful in terms of prognosticating in your cardiac arrest patients. But there are multiple examples of cases where a low end-tidal CO2 eventually came up with adequate resuscitation. So we can't use that in isolation. How about echo? Cardiac ultrasound, cardiac standstill means they're dead, doesn't it? With most patients, yes, but again, there are numerous exceptions to that rule. Now, I'm not saying that you shouldn't use these. I use these all the time, but don't use them in isolation. Use them in the clinical context, and remember, there are always exceptions. But if you are really, really keen to make an ignorant and stupid decision on terminating resuscitation, please feel free to use the blood gas. I was a registrar in a major teaching hospital in the UK, and a guy in his 40s came in with sudden collapse. Really fit guy, came in, and He was in a PEA cardiac arrest. He was cyanosed to a degree that didn't reflect the amount of oxygen and good resuscitation that was happening. He had a large cast on his leg from a very recent Achilles tendon repair. Not a difficult differential diagnosis to construct. And I was very, very keen to thrombolize this probable massive PE. But I was discouraged and told, we're in the teaching hospital here, we have cardiothoracic surgeons, let's get them involved in case surgery is an option. So we didn't thrombolize him. We tried to get hold of the cardiac surgeons. We paged them, we phoned them. Eventually, the anesthetist on the team said, I think I know where they hang out, I'll go and find them, dragged them out of the theater coffee room, brought them down. They asked for a blood gas. Who thinks that blood gas was normal? Good. They looked at the gas and on the basis of a low pH said, there's no chance of a successful outcome, and called it. Funnily enough, they were not there when I was breaking the news to his wife and his little daughter. And so that case on its own infuriates and upsets me. But there are so many multiple examples. You see this all the time. So here's one from a friend of mine who works overseas. He's a retrieval medicine physician. He went to pick up an 8-kilogram, 8-month-old baby who'd got accidentally left outside in the snow and was in cardiac arrest, had a temperature of 18 degrees. This baby was resuscitated but remained in cardiac arrest, and my colleague phoned ahead and asked for ECMO to be set up at the receiving center. By the time he arrived at that receiving center, the baby had been in arrest for 2 hours. The ECMO guys asked for a blood gas. The pH was 6.5, so they said to call it, they weren't going to provide ECMO. My friend, in his words, said that he absolutely begged them to give that child a chance. So they said, okay, whatever, we'll do it. That kid was back in its mum's arms, feeding normally within a week or two. So please don't make decisions purely on a blood gas. Think about the patient with status epilepticus who someone takes a gas from, or the bad DKA. Do we palliate those? No, we don't. Think about the Olympic rowers who drop their pHs down into the high 6s. All right. Okay. So cases like that do infuriate me. And they're self-fulfilling for those individuals. It confirms their own biases. I've never seen a patient with a pH like that survive. Yeah, well, that's because you never resuscitate them. So they all die, so that you believe they can't be saved. And sometimes it's difficult because there's some facts in the history that make you want to carry on with this patient. They had really good CPR from a bystander, really good pre-hospital ACLS, and they're still looking okay. But sometimes it's slightly more subtle than that. Sometimes it's the color or the tone or an occasional swallow or some element of aliveness about this patient in cardiac arrest with no pulse. And I had a case like that I needed a serious debriefing from an expert about. And this was a 45-year-old who had an out-of-hospital VF arrest after playing sport. No previous medical history, degenerated to asystole. We brought him into hospital, continued CPR, did various things. He was in and out of ROSC temporarily, but then we kept losing an output. But all the time, this guy looked well perfused. He was lacrimating, he was swallowing, there were occasional movements. The guy was crying, and we had to stop resuscitating him because we ran out of options. And I had to go on Scott's couch and just debrief this. And I mean, this was a very long time ago. He was only on podcast 82. It's ages ago. And it was a helpful debrief, but still to this day, I believe that more could have been done. So let's tackle that. There's nothing else you can do. We often call it because there's nothing else we can do. Now, why do we believe that? If we think about the way we train in advanced cardiac life support, the courses, the algorithms, they make us think that after providing some CPR, giving adrenaline, going through a few cycles, and a cursory consideration of the underlying causes, it's appropriate to stop. There is nothing else we can do. It's almost a license to discontinue. And I think that's a shame, and I think it's flawed. And incidentally, with these ALS guidelines, when you read them in depth, there's always a chapter on special circumstances where you're allowed to go on a bit longer, like where it's a kid or it's hypothermia or drowning or whatever. Just let me tell you now, okay? If I come in cardiac arrest, that is a bloody special circumstance, all right? Please go on a bit longer. So what's wrong with this? I think people get confused because they think the algorithm is the treatment. They think the algorithm is the treatment. The CPR and the adrenaline is not the treatment for cardiac arrest. It is the organ support that allows you to treat the cause of the cardiac arrest. And the H's and T's themselves are limited, which I'll go into later. And I think if you think about it that way, you can separate your team. We were told the other day that nurses can provide excellent ALS, and I totally believe that. And my preference is in a team, is a nurse is leading the running of the algorithm, providing quality CPR, ensuring the timing's right, guiding those adrenaline doses and timings. And then the rest of us, the separate team, the team leader can concentrate on the underlying cause, the echo, counseling and getting a history from the family, getting in that arterial line to guide the vasopressor therapy, getting the cardiologist to get cath lab ready because you're going to bring this patient up to the cath lab with ongoing CPR, getting the ECMO team ready if that's an option in your center, checking the electrolytes, really thinking through what else can we do, and not worrying about the CPR. And even better, if you have machines to do your basic life support, like mechanical chest compression devices and a ventilator, why worry about it? Leave that to the machines. Get on with the other stuff. So what else can we do? Let's take the rhythms, the way it's taught, VF, what can we do? Well, the algorithm says shocks and drugs, more drugs if necessary. But there's other drugs that have been discussed during this conference that may come onto the scene, that may make a difference. Upping the energy, changing the position of the defib pads, that's all good. But remember, if the underlying cause isn't removed, they may stay in VF. So if you need to get them to coronary revascularization on the Lucas device, or even with manual CPR, have systems in place for making that happen. If there's an electrolyte disturbance, fix that. And then one other thing that seems kind of out there, but that's being evaluated at the moment in the States after some interesting case reports, is the concept of double sequential external defibrillation. One defib, if that's not good enough, two defibs must be better. So actually getting two defibrillator machines, putting the pads in different places to change the vectors, and providing two shocks as simultaneously as you can, which usually results in one shock followed by another in rapid succession. What can you do about the electrolytes? We had a case in our retrieval service of a young man with diabetic ketoacidosis and who had prolonged seizures and was found down, arrested on arrival in the emergency department, had a potassium of over 10. Multiple doses of the calcium, of the insulin, of the bicarbonate, of the beta agonists, but no sustained return of circulation. So what could we do? This was in a small hospital with no access to renal replacement therapy. We just worked out how to peritoneally dialyze this guy in the resus room. We got his potassium down to 5.4 by the time he arrived on the receiving ICU with a good circulation. Now, did we do the right thing? I don't know. The guy did not survive to ICU discharge. But his mum got a chance to hold his hand and say goodbye, and to speak to some doctors and nurses that knew him and could break the news to him and let her spend some time with him. Maybe it was the right thing, I don't know. But I'm convinced it would have been the wrong thing not to try everything we could have done for that 30-something-year-old patient. What about asystole? Often feels futile to be doing anything to these patients. And the causes, of course, the underlying causes are the same as the causes of PEA. But just occasionally, keep at the back of your mind, sometimes this is due to a primary or secondary failure of conduction tissue. And you can make a quick diagnostic test of this with percussion pacing. Little thumps on the lower sternum or over the apex, rate of 60 to 70. Not like a precordial thump, but little percussion pacing movements like that. If you get capture, that's fantastic, and you often do. But you don't always get mechanical capture. You need to assess that, the presence of a pulse or echo. But if you do, you can make a difference to these patients. And we'll go on to PEA, but we'll just clarify some terminology first, okay? Pulseless electrical activity. You have no pulse, but the monitor shows a rhythm. We all understand that. If the heart's not beating, that's worse than if the heart's beating. Because if the heart's beating, all you've got is a really hypotensive patient with pulses that are impalpable because of severe hypotension. The causes are the same. They're just different ends of a spectrum. Now, we used to call the heart not beating situation electromechanical dissociation. Got electricity, no mechanics. It's dissociated. But if the heart's beating when you look at an echo, well, it's only pseudo-EMD. They're not really dissociated. There is mechanical activity too. Somewhere along the line, the last iteration of the guidelines, I think some people from ILCOR got a bit confused and changed the terminology to true PEA and pseudo PEA, which is the current terminology, which doesn't, to me, make any sense whatsoever, because they're all pulseless electrical activity. They're all true pulseless electrical activity. But know what you're looking at. Make that early echo assessment. Is the heart still beating? And thinking about the underlying causes. And of course, the H's and T's are a flawed mnemonic tool, and they are limited in what they provide, but we'll talk through some of them. Let's take trauma. What do patients arrest with in trauma? Hypovolemia, tension pneumothorax, cardiac tamponade. We should be focusing our efforts on identifying and managing those causes. And it should be self-evident to everyone in trauma centers that external cardiac compressions and intravenous epinephrine, adrenaline, are not going to make any difference, and potentially deleterious in some cases. But you still see it in the major trauma centers in the major cities, and I don't understand why. What can we be doing? We can be doing open thoracostomies, decompressing those pneumothoraces, which are notoriously difficult to detect clinically, and which are inadequately managed by needle thoracocentesis. In penetrating cardiac trauma, we can do a resuscitative thoracotomy. Is where you work capable of providing that 24 hours a day? And if not, why not? And we heard from Kareem Broey and the patient with exsanguinating lower body trauma. Resuscitative endovascular balloon occlusion of the aorta, REBOA, is now a realistic option in some centers. It's amazing. There's always more we can do. With the H's and T's, the reason I think they're limited is because they're predicated on the assumption that they have to be fixed by the provider in the EMS system or in the ED. But there are other things that are treatable, that are reversible, if you can provide that organ support for sufficient time. If you've got congenital cardiac disease and you arrest, that's not in the H's and T's, but you can fix that with surgery. If you've got myocarditis, that's not in the H's and T's, but that gets better on its own. You've just got to keep the patient alive. And one way of doing that is with extracorporeal life support, ECLS. Visit this website, listen to this podcast. It will open your eyes, it will change your view of cardiac arrest. And it's forcing us as a profession to reappraise the significance of cardiac arrest as an entity, and forcing us to question what is the point now at which we can say with confidence this patient is irreversibly unsalvageable. Because I don't know the answer to that every time I read a report of someone who's had 2 or 3 hours of CPR before they go on to ECLS, before they make their full neurological recovery. So it's tricky. But I'm talking about technology and medical interventions. But I'm a big human factors guy. And I know most of these cases that could be saved that aren't down to not having an ECMO service in your hospital. They're down to individual decision-making and team behavior. And let's give you 2 pediatric examples that show this. Now, these are, of course, anecdotes, right? You might want to read an RCT, but I promise you never will on the stuff I'm going to talk about. And anecdotes may not be great science, but an N of 1 is pretty powerful if that's your child. So 2 stories from overseas, from retrieval medicine specialists in different countries, modified sufficiently so you shouldn't be able to identify the cases. The first one, this is a 3-year-old boy. He submerged in an icy lake for 20 minutes. His parents got him out. They provided basic life support. They called an ambulance. EMS got there within 20 minutes. They continued basic life support, put a laryngeal tube in. They noticed his pupils were reacting, and the retrieval service had already been deployed. It was an hour's flight from the base. My colleague got there, intubated the child, noted a good end-tidal CO2, relatively good, 20 millimeters of mercury. Pupils were reacting. Patient was in PEA with a rate of about 80. And they activated the ECMO service at the receiving center. Continued CPR en route, all the way en route. The pupils were reacting, the end-tidal CO2 stayed good. in the same narrow complex rhythm, about 80. When they arrived at the receiving hospital, the cardiothoracic surgeon, the cardiac anesthetist said, it's still in arrest, there's no point, we're not going to put them on ECMO. My colleague pleaded with them, they said no. He said, but the kid's heart's probably beating. Let's have a look with an echo. Would you do it if there's still some cardiac activity on echo? They agreed to let him do that, but they did not agree to the continuation of CPR while they got the slow ultrasound machine to warm up. And by the time they looked at the heart, it had bradyed down into asystole, and they called it. That was the first case. The second case is an 11-year-old with a Fontan circulation. If you don't know what that is, he's had some surgery for congenital cardiac disease that essentially leaves him with one functioning ventricle, but it's compatible with a good life. He's 11. He's at school. He faints at school, so gets taken to hospital. He's awake on arrival to hospital, but then arrests. Some very good CPR, very good teamwork goes on. They conclude this child may need ECMO. They call the receiving center, that again is a long flight away. The ECMO center says, or the surgeon there says, we don't believe patients with this type of circulation are salvageable once they arrest, and we're not going to take this patient. Please discontinue CPR. The team leader says to the 22 people in the resuscitation team, we need to stop, they're not going to do anything. Is everyone happy to stop? One guy, the retrieval guy, puts his hand up and says, we cannot stop, please don't stop. And the reason for that, this child had reactive pupils, he had a good end-tidal CO2, he was moving, he was going for his tube, even though he was in cardiac arrest. He had this aliveness, these signs of life. This guy just could not stop. Racked his brains and remembered reading something somewhere that patients with Fontan circulations have a sluggish circulation. They're very prone to venous thromboembolic disease. He said, just maybe the response to thrombolytics, can we try that first? And then we'll stop. And they went, okay. So they gave him intravenous thrombolytics. 15 minutes later, he had return of spontaneous circulation. He was hemodynamically stable on arrival at the receiving center. A few days later, he was seen by my colleague playing with other children on the pediatric ward. So those are two interesting human factors side to things. I mean, it's high-tech medicine, but it's those individual decisions that are making this permanent and devastating result for one of those families. In the first case, the whole system was geared towards saving that child, but the individuals who owned the machine said no. On the second case, everyone was ready to pull out, except for one guy who put his hand up and said, please don't stop, let's just try one more thing. So, I was given this talk, when to stop resuscitation. Sorry about that. I have told you when to stop resuscitation. I've given you those pointers, patient doesn't want it, there's nothing else you can do, etc., etc. All right, but I've also tried to explain and give examples of when it's so difficult to make that call. And I have essentially turned this into a when not to stop resuscitation talk. And the reason for that is simply this. Life is precious. You are incredible. If you think about the amazing improbability of your existence. So random sperm and random eggs have come together on random rainy nights so many times over so many generations, 185 million generations going back 500 million years to when your ancestors were fish. And then if you think about it beyond that, 13.8 billion years of universal evolution and physics and time and chance to create you, who are amazing, incredible, complex examples of biological beauty. Even Min Lakong. But then some muppet can go and snuff it all out with an ignorant and lazy decision on a blood gas. And your job is not to let that happen. Your job is to go back to your emergency departments and your ambulance services, your operating theaters, your intensive care units, and just ask the questions, challenge your colleagues, challenge yourselves. Do we have this kit? Do we have these systems? What else can be done? That 57-year-old bloke who died with a VF on the first day of his retirement, I don't think anything else could have been done for him, but he had a 19-year-old son who was at medical school, and he's here now talking to you, and he will not cry on stage this year. And yeah, I'm determined to make a difference to these patients. I can't bring my dad back, nothing can. But I'm damn sure we can do more for other people's dads and mums and kids and siblings and mates. Major Samantha Olsen, if you're here, your mates. That's who we're there for. Because I think as people, the important thing about human life is it's about other people. It's about connection and it's about love. And I think as resuscitationists, we are motivated by love. We are motivated we are motivated by love for other people. Okay? And I think it's that love for other people that makes us feel it's unacceptable not to do everything we can, not to go that extra mile, to do everything we can for those patients who are not ready to die. Thank you.